Hello, I'm Mary Simron de Cruz and I will be presenting a mind map on a case study on heart failure with reduced ejection fraction. I will also be discussing its etiology, pathophysiology, clinical manifestations, nursing management, and pharmacological treatment specific to the case. Etiology. According to the National Heart, Lung and Blood Institute, the major contributing factor to heart failure with low ejection fraction is chronic diseases that harm or deteriorate the heart muscles. The heart muscle may not receive enough oxygen, for instance, as a result of coronary heart disease or a heart attack. There are multiple causes of heart failure, including systemic diseases, hereditary defects, and cardiac conditions. Malik et al. 2021 explains the etiologies of heart failure between high-income and developing countries, and patients may have mixed etiologies. The main cause of heart failure for patients include chronic obstructive pulmonary disease, which is common among patients who smoke. Other causes include hypertensive heart disease, which is also a possible cause of heart failure for Mr. Cavalry in our case, because he has had hypertension for several years. Hypertension is classified as an independent risk factor of congestive cardiac failure since it causes 1/4 to 1/3 of heart failure cases. Cubero et al. 2021 states that hypertension leads to vascular resistance and activates the renin-angiotensin-aldosterone system. To restore proper cardiac contractility, the heart must pump blood against an elevated afterload resulting from hypertension, which enhances myocardial volume as a compensatory response. As a result, left ventricular hypertrophy increases. Left ventricular hypertrophy causes myocardial stiffness, which causes ischemia and heart failure with low ejection fraction. Pathophysiology. According to Abbasi et al. 2021, the pathophysiology of heart failure with low ejection fraction includes cardiomyocyte dysfunction, where the heart muscle cells may become damaged, causing a decrease in the heart's ability to contract and pump blood. Cardiac remodeling causes the heart to enlarge and be stiff, making it more difficult for the heart to fill with blood and pump it out. Arrigo et al. 2019 also states that heart failure with low ejection fraction causes the neurohumoral system, such as sympathetic nervous system and the renin-angiotensin-aldosterone system, to increase blood flow, causing further damage to the heart and blood vessels. Malik et al. 2021 adds that heart failure leads to decreased carotid baroreceptors response, increasing sympathetic nervous activity, and increasing the cardiac contractility and heart rate, afterload, and vasoconstriction. The combination of these mechanisms leads to decreased cardiac output, pulmonary hypertension, congestive heart failure, and weakening of the heart so that it cannot pump blood. Additionally, due to the heart being too weak to pump blood, the blood pools at the front of the heart, causing abdominal and peripheral edema, which can explain the patient's current symptoms and rapid weight gain. Clinical manifestations. Mr. Cavalry has peripheral edema and a rapid increase in weight. Since he was admitted, he has gained 1.5 kilos. Jan Skwarski et al. 21 explains that there is a unique relationship between the kidneys and the heart, which play a central role in the patient's symptoms. The interplay between these organs involves numerous independent mechanisms, such as the hemodynamic alterations leading to insufficient peripheral and renal perfusion that can cause renal tubule hypoxia. This interplay also explains the symptoms of low urine output at 20 mL an hour, which is concerning since the normal output is above 30 mL an hour. Studies indicate that low urine output is a straightforward indicator of acute kidney injury. As seen in the pathophysiology of congestive cardiac failure, persistent activation of antidiuretic hormone, the sympathetic nervous system, and the renin-angiotensin-aldosterone system causes deleterious effects on the kidneys and the heart, causing water and sodium retention. Seferovic et al. 2019 also explains that increased central venous pressure and vasoconstriction are linked to renal venous hypertension with increased intra-abdominal pressure. The activation of the neurohormonal systems causes salt and fluid retention, leading to pulmonary congestion, peripheral edema, dyspnea, and fatigue. Consequently, peripheral edema leads to weight gain due to excess fluid retained either from forward failure or from backward failure of the kidneys. This retained fluid adds to the weight gain of the patient. Tachycardia, persistent cough, and tachypnea are symptoms the patient has exhibited. Kubera et al. 2021 indicates that heart failure can lead to tachypnea due to the inability of the heart to pump blood, causing pulmonary edema. This leads to difficulty breathing and increased respiratory rate as the body tries to get more oxygen. Due to pulmonary edema, there is an irritation in the airways which explains the persistent cough. Additionally, due to increased pressure in the pulmonary vessels, fluid is leaked into the air spaces in the lungs, which is coughed up as phlegm. This cough is usually worse at night due to fluid accumulation in the lungs when lying in horizontal position. The patient also has a fluttering feeling in the chest. Heart palpitations are common for patients with heart failure. This is precipitated by tachycardia and arrhythmia as the cardiac muscle tries to compensate for the reduced pumping reliability. Additionally, due to pulmonary edema, patients may have experienced palpitations, shortness of breath, and fatigue. It also explains the low oxygen saturation rate of 92% despite being on 2 liters of oxygen. Nursing management. The first nursing management plan for Mr. Cavalry is relieving fluid overload symptoms as evidenced by rapid weight gain, 1.5 kilos since admission, edema, and shortness of breath. The nurse should monitor for signs and symptoms of fluid and electrolyte imbalances as per the patient's symptoms, oxygen saturation, and ABGs. The nurse should provide oxygen. Secondly, it is critical to enforce fluid restrictions and educate the patient and his family on the importance of adherence. It is also critical to record accurate fluid intake and output, including IV fluids and water taken with medications. His weight should also be monitored daily. The nurse should also encourage the patient to keep the legs elevated in a comfortable position to avoid pressure under the knee. Secondly, the nursing management would be to manage cardiac output as evidenced by tachycardia, decreased urine output, and cool, ashen skin. The goal of this management is to ensure the vital signs remain within acceptable limits. The nursing assessment here includes noting heart sounds since S3 or ventricular gallops may be heard during auscultation. S1 and S2 may be weak due to decreased pumping action. It is also critical to assess for palpitation or dysrhythmias, which are secondary to chronic heart failure. The interventions include providing oxygen as indicated by the patient's symptoms, ABGs, and oxygen saturation. It is also critical to ensure the environment allows for rest periods. The patient should be repositioned every 2 hours to prevent pressure ulcers. Finally, the nursing management includes patient education as evidenced by taking 2 to 3 glasses of grappa every night despite being on 1.5 liter fluid restriction. The goal of this is to prevent recurrent preventable episodes. It is essential to assess the patient's understanding of his condition's dietary and exercise needs. Potential pharmacological treatments. The pharmacological treatments for congestive heart failure include diuretics, vasodilators, inotropic agents, beta blockers, anticoagulants, angiotensin-converting enzymes ACE inhibitors, calcium channel blockers, nitrates, and angiotensin receptor blockers ARBs. The ACE inhibitors such as ramipril, enalapril, and lisinopril are the first agents used for patients. These work by increasing the vasodilation and decreasing the heart's workload. Since the patient is experiencing a cough, one of the main side effects of ACE inhibitors is coughing. The other side effects of ACE inhibitors includes fatigue, dry cough, headache, loss of taste, and hyperkalemia. Therefore, ARBs such as losartan, candesartan, and termisartan are used. The side effects of these medications include headaches, fatigue, fainting, dizziness, vomiting, and diarrhea, leg swelling and respiratory issues. Diuretics such as furosemide, torsemide, and thiazide are critical since they help remove excess water, salt, toxins, and accumulated metabolic products. These will help decrease peripheral edema and improve his breathing. The side effects of diuretics include dizziness, muscle cramps, gout, dehydration, and headaches. The nursing consideration for cardiac medication include monitoring for dehydration, electrolyte depletion, hypertension, edema, and urinary retention.